I don't know where this train goes, but it's so slow. All I know is my love is waiting on me. Take me home. I've got a question. Are we on the same page when it comes to obsession? I look to the sky, count my blessings, but how can I do that when my mind ain't bright, losing stride, while the love of your life keeps taking you aside through the darkest of lies? I've been second place before, it wasn't worth the fight, but then my heart pipes up, sprinting again, head's begging it to stop. It's too right, wrong time for a drop, but you throw me a gaze, all the fingers don't flop. I don't need that, la 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 la. All my peers say, let me adore you, but I just wanna learn you. Yeah, it keeps on rolling. I don't know where this train goes, but it's so slow. All I know is my lover's waiting on me. Take me home. Man, I'm stuck at a crossroad. Where am I soul? Waiting on the devil to turn up, but he's a no-show. In the silence.
Hi, welcome. Welcome to Diabetes Dialogues. On behalf of MLI and Endo, we'd like to thank you for choosing this symposium, Beyond Inertia, Advancing Type 2 Diabetes Care with Innovative Basal Insulin Strategies. This activity is supported by an educational grant from Novo Nordisk. So tonight we're really going to take a casual, candid conversational approach to talking about basal insulin therapy and type 2 diabetes. We're going to talk about some of the innovations that we've seen, some of the strategies for initiation, for integration, collaboration, and patient empowerment. We'd also like you to contribute. So we're using an audience response system called Kahoot. You'll just use your phones. So if you haven't already, if you could scan the QR code that's on your table. If you're online, you can go to kahoot.it and click in the number that will come up on the screen, and it'll put you right into our activity. Now, we will have a competition in the end, and we do have bragging rights for the rest of Endo 2024, but in addition to that, we have for first, second, and third place a $175 gift card, a $150 gift card, and a $100 gift card for Amazon. Now, speed and accuracy is the name of the game, so please answer as quickly and correctly as possible. The last thing I'll say is we have downloadable resources, so if you see something in today's program, I know there's a animation mechanism of action that you're interested in taking back and sharing with your colleagues, there's a card on your table. You can scan that QR code and take that home. Now, without further ado, I'd like to introduce and turn the program over to Dr. Thomas Pieber. Thank you.
Thank you and welcome. Thanks for coming. Thanks for joining us. We really try to make it interactive. And first, before we start, I want to introduce our speakers today. So I'm Thomas Pieber. I'm from the Medical University in Graz in Austria. I have the pleasure to chair this session. On my right side, there is Eda Cengiz. She's professor of pediatrics of the University of California, San Francisco, and they're director of the UCSF Pediatric Diabetes Program. On the other side is Stephen Steenkamp. He's director of clinical diabetes in the section of endocrinology, diabetes, and nutrition at Boston Medical Center at Boston University. So together we would like to discuss with you about these novel treatment options that are currently announced and that are approaching us. Here you can see briefly the learning objectives. I'm not going through them in detail. We have some test questions for you in the beginning, at the end. please use the system that you have been shown, the Kahoot system, and we start with the first question in a second. Okay, so thanks for joining here. Let's get rolling. And the first question is an easy one. That's a warm-up question. What will you be doing after tonight's symposium? You can select different options from going to bed or going out or doing more science. And we want to see if the system works, so please select one of the answers here. Okay.
Bed, going to bed, okay. Fair enough.
Most of you will go to bed. Okay, so what describes your profession best? Please select which background you have so we can look at that after the... Okay, so we have several professions here. Thank you. And then, which of the following best describes your professional focus? Is it general endocrinology, diabetology, endocrinology and obesity, or primary care, or other focus? Good, and now we can start with the pre-test questions. So those questions help us to see the learning progress you will make tonight. So how confident are you in addressing significant challenges in utilizing basal insulin therapy for managing patients with type 2 diabetes? If you are not at all confident to highly confident, please again select how you feel, how confident you feel. So we have a challenging job to increase your confidence. And how confident are you in incorporating novel once-weekly basal insulin formulations into the comprehensive treatment plans for patients with type 2 diabetes? Again, from not at all confident all the way to highly confident. Okay, so here we hope that we can work together and improve the knowledge. So let's start with the first patient case as a pre-test. So a 49-year-old man has been diagnosed with type 2 diabetes 7 years ago and was referred to you by his primary care physician. The most recent HbA1c was 8.2. He's currently prescribed metformin twice daily. And glipizide, 10 milligrams in the morning. And he has a BMI of 38 kilograms per square meter. So alongside lifestyle and dietary interventions, what medication adjustment would you suggest? Please again choose the option that you think is the best fitting for this patient here. Thank you. The next patient is a 62-year-old female with type 2 diabetes diagnosed 5 years ago. And she presents for a routine follow-up visit. Despite lifestyle modification and metformin twice daily, HbA1c remains elevated at 9.2. She denies any symptoms of hypoglycemia and reports adherence to her current medication. BMI is 24 kilograms per square meter, and there are no signs of micro or macrovascular complications. But she reports an increased urination frequency. Fasting blood glucose averages around 180 milligrams per deciliter. Again, we would like to know which of the following represents the most appropriate next steps. Please choose again your answer. Now we know why you feel confident with your diabetes knowledge. And which of the following statements best describes the pharmacokinetics of once-weekly basal insulin? Steady-state insulin concentration is achieved within 48 hours. The duration of action is primarily determined by the absorption rate. A constant concentration profile over the dosing intervals is exhibited, and genetic factors influence PK, resulting in inter-individual variability. Or you're not sure?
It's okay if you don't know. These are pre-test questions, so no stress.
So here comes our next question. In a systematic review of real-world evidence by Robinson, approximately how many missed basal insulin doses in a month were found to significantly impact glucose control? 2, 4, 6, or 8, or you are unsure? Well done. It's 4. Now we have a word cloud. So what word describes your greatest challenge in utilizing basal insulin therapy for managing patients with type 2 diabetes? Please type in what word describes your greatest challenge for using basal insulin therapy in the management of type 2 diabetes. Compliance and cost. Fantastic.
That would have been my choice too, yes.
Okay, thank you for your participation. Now we can get started. So in the first part, we would like to address some of the barriers to appropriate basal insulin therapy initiation. And I want to start here. That highlights the fantastic development that we have seen in the last 25 to 30 years when it comes to basal insulin. So many of us might remember still the time when we were using MPH insulin. You had to give this twice daily. You had to resuspend it, and resuspension together with the crystal formation is one of the reasons why MPH insulin was associated with a rather high frequency of hypoglycemia. Then first-generation basal insulin analogs like insulin glargine or insulin detamir were introduced. We then saw the second generation with insulin glargine U300 and insulin degludec in U100 and U200 concentration. And those 25 years showed also that for basal insulin therapy, we need a flat profile, we need a profile with low variability. And the question is now, what kind of insulins might we have in this third generation basal insulin analogs? How long can we stretch the duration of time to action? And despite the improvements and the once daily basal insulin that we are using currently, there are still some challenges that remain. So some of them have been, or many of them have been mentioned by yourself just in the word cloud. So dose administration, the timing and the multiple injections that patients need, the risk of hypoglycemia that's linked with insulin therapy, the frequent dose adjustments, the high number of injections. When you have a daily basal insulin, it's 365 days per year where you have to inject your basal insulin. Adherence, a major challenge for our patients. We will come back to that. Weight gain, fluid retention, and then last but not least, only a small subset of our patients, between 5 and 45, maximum 50% of our patients are achieving the desired glycemic controls when we look into real-world data. So there is room for improvement when it comes to these therapy options. We also should listen to what patients are saying. So these are true patient statements, and they, for example, highlight the weight concerns. I've recently been put on insulin and put on 28 pounds. It's making me more miserable than diabetes does. Any advice on shifting insulin weight? This is one of the problems we know quite well in our patients. Another concern is related to dosing and injection challenges. Ken says, yesterday I screwed up my basal injection and lost some of it, probably about half of it. I did not try to take any more because I didn't know how much I got. So those are challenges that our patients are facing, and this is a survey that has been published recently, and it shows the prevalence of insulin wasting, and you can appreciate that only roughly one third of the patients never is wasting any insulin. It's pretty common in 40 to 50% that more than once per month there's insulin wasting. And there's also prevalence of shorting, so reducing the insulin dose because, for example, there's not left enough in a pen for the next injection. Then patients are shortening their insulin injection. And this all adds up to the problems we have then with the glycemic control. And this is also associated with some stress. Another survey, or the same survey that was looking into those challenges. And people find it stressful when, for example, they throw away leftovers of long-acting insulin, when they realize they have to inject twice because the leftover is not does not have enough units. Sometimes they are not injecting the rest of the insulin, and they realize that 2 injections are needed, and then people stay away of that second injection. So this is a pretty common phenomenon when it comes to basal insulin use. And healthcare professionals know that well, and they contribute a substantial stress for their patients when this is an issue. And then another problem we have are missed doses. So this is the percentage of people who miss their insulin dose, and some of the reasons, the main reasons. So overall, almost 40% of the people miss at least 1 dose per month. When they have more injections, this is more likely, which is easy to explain. It's almost 50%, and the main reasons are they are forgetting, they're falling asleep, or they are too busy to do their insulin injections. So there are also provider-level barriers that contribute to underuse of insulin. So we perceive these patient barriers. There's concerns regarding patient acceptance, the fear of hypoglycemia, the perceived complexity of insulin regimens, and time constraints. And unfortunately, there's something what we have to call therapeutic inertia. So many of the patients do have an HbA1c around 8% for the last 3 to 5 years before insulin is initiated. The current guidelines also might contribute to a negative perception, like insulin is the last resort. There sometimes is also a lack of team experience and confidence in treatment intensification for our patients, and then incomplete knowledge of underlying pathophysiology also might play a role. Again, we are listening to our patients. So Peter says, my doctor tells me insulin is a last resort. Due to when you take it, your body stops the production of your own. So once you start on insulin, you will be dependent on it. This is a misconception that is quite common, unfortunately. And we would like to discuss a case together with you. So Mr. Smith is a 64-year-old man with a history of type 2, diagnosed 10 years ago. He presents to his physician's office for a routine follow-up. His current medications include metformin twice daily and glipizide daily, and his last HbA1c was 8.5%. Despite adherence to his medication regimen and lifestyle modifications, Mr. Smith's blood glucose control remains suboptimal, as evidenced by his elevated HbA1c level. So I would like to ask you, or my co-speakers here on the podium, what they think about such a case. Who wants to start and has an opinion on that? We have microphones, so you raise your hand and you can help us. Anyone who wants to break the ice? Yeah, thank you.
So I am a lonely family medicine resident who decided to crash this party. But let's see, he's on metformin and taking glipizide. He's 64 years old. He's not at goal. I think the textbook answer, based on the board questions I repeatedly get wrong, would be ditching the glipizide. I mean, the metformin is questionable depending on which guidelines you're following. And I think GLP-1 would be awesome if I can get it covered.
Yeah, thank you. Other opinions?
There's one over there.
Usually in this case, I will not ditch any other medication, but I will give them written instructions. If they start having hypoglycemia, then they need to stop the glipizide, but I would continue those two and add a GLP-1.
Thank you. Other ideas?
I saw one hand over there, but I may be wrong. Yeah.
Yeah.
Yeah, I would probably change glipizide to two other agents like GLP-1 and the SGLT2 inhibitor. It will save them from having hypoglycemia and give them extra benefit, as a glycemic benefit.
Yeah, thank you. Very good. So I think we have covered most of the options. Is there? Yeah, we have another opinion. Thank you.
Added incretin mimetic. I saw his BMI was 38 or so. Put him on Mounjaro or the Ozempic.
Yeah, thank you. Anything from your side?
No, I think it's all good answers. I'm surprised, given that we're talking about insulin, that nobody's adding basal insulin. I'm not saying that I necessarily would, especially with someone who's, as you mentioned, got a high BMI and on glipizide already. But that's all I would say. I wouldn't add it personally, but I'm just throwing that out.
Yeah, let's see what we say at the end of this evening, how valuable basal insulin might be. Yes?
The treatment, because even if we are choose to start basal insulin, we have no idea about the fasting blood sugar, the glycemic profile. The phenotype of the patient must be addressed. Also the comorbidities, because even if we select the SGLT2 inhibitors, we don't know about what is the indications, the contraindication. So the knowledge are missed. We must address some renal functions and glycemic profile and comorbidities.
Yeah, thank you. So this is important to have more clinical information to really decide on what the best therapy for this patient would be. Thank you very much. Yeah, there's another. Mics are coming.
When it comes to this kind of patient, the things that we don't know the BMI up there. But say this is a 64-year-old person with a BMI of 24 who's been on glipizide, and they're not to goal, so it makes you wonder whether they've got pancreatic insufficiency, islet cell insufficiency, and maybe they do need insulin. So I actually would consider checking a C-peptide to see whether or not this patient is insulin deficient, absolute insulin deficiency.
Yeah, thank you. Yeah, we will come back to this in a minute, I guess.
Great. So I'm going to play the role today of starting off some panel questions for my colleagues, and then I'll jump in as well. But I'm going last in the speaking, so I'm going to do this in the first two sessions. So I'm going to pose this to Etta and Thomas here. So here's a patient situation. And so in the light of the challenges that we've just spoken about related to this patient, and now we have all these fancy new medications that just keep getting more and more. Whether we can get them or not is a different question. Is there still really a role for basal insulin?
Why not? I mean, I think you made an excellent case. You know, we need to know more about this patient, you know, what's going on with C-peptide. If this patient has a very high BMI, I might go towards like GLP-1, but you can always add something depending on what's going on with the situation and the presentation. So I think there's no one straight answer, but definitely basal insulin might be an option for this patient depending on what's going on. Is it a catabolic stage? What's going on with C-peptide? And I think that basal insulin would be an excellent choice.
Yeah, I think the weight is always a very good indicator if someone is likely to need insulin. The more weight loss occurred in the past, or the less obese someone is, the more likely basal insulin is an available option. There's no strict rules for that, but I think it's a good clinical indicator for us. So if we see a lean type 2, it's very likely that those patients will need insulin. And sometimes we start pretty late because we have so many treatment options. We have all mentioned them. They are fancy, they are nice. They are talked a lot about. So sometimes we're forgetting that insulin, if insulin deficiency is the driving cause for the hypoglycemia, that insulin is a very good candidate.
And the only thing I would add, I think, to our two colleagues over here and at the back, just to those two comments, I think you're right. You really need clinical data, and then there's a shared decision-making process with patients. And for some patients, basal insulin may be something that they prefer, depending on what their comorbidities may be. If they have gastroparesis or something else, a GLP-1 is going to be a hard sell potentially, or they have significant issues there. And then also a duration of diabetes. If they've been living with type 2 diabetes for 30 years, are we really going to have much beta cell benefit in terms of trying to ask the beta cell to do more when the beta cells are already tired or no longer there? So,
I just have a comment to add. I'm also a nurse practitioner, and I would want more data in terms of glycemic patterns and looking into whether this is prandial hyperglycemia or maybe fasting hyperglycemia before I'm going to make a decision as far as what to do with glycemic control. And I may going to opt for basal insulin in case if patient is based on the patterns, or maybe on a temporary basis to make patient euglycemic while I am entertaining GLP-1 and SGLT2 therapy.
Yeah, well, great points.
Great points, yes.
Good, thank you. So let's listen again what patients are saying. So Kyla says, I'm type 2 and on fast-acting insulin with meals and a long-acting insulin at night. I feel so much better in myself. Sugar levels are under control now. I've tried lots of different tablets and nothing helped. Just nasty side effects from them all. So this is one of the typical patients where insulin or starting insulin therapy sometimes is perceived as a relief from diabetes symptoms, many medications, all medications, where they have the feeling they are not working. And there are good reasons why we sometimes don't realize early enough that someone needs insulin, and this slide shows us the three major contributors for hypoglycemia in type 2 diabetes over the time. So when someone starts with normal glucose tolerance and then develops impaired glucose tolerance and insulin resistance, this insulin resistance, mainly driven by body weight, remains. And because there is impaired glucose tolerance, we do have already some of a beta cell dysfunction. Usually when our patients are diagnosed, and this comes from UK BDS data and from many other cross-sectional data again and again, a diagnosis typically roughly 50% of our insulin secretion capacity is already impaired or lost. And over time, when then patients are treated and patients are entering a later stage, insulin resistance remains, but with increasing beta cell dysfunction, of course, also hepatic glucose production increases, contributing to the hypoglycemia. And then it's definitely time to think about insulin and basal insulin as a very good starting point for our patients. So there is also good pathophysiological reasoning that at some stage we will need insulin. So let's move closer to the topic. What are new third-generation basal insulins? What is to be expected? So the idea is to have an extended time action profile that allows for once-weekly insulin administration that should more closely mimic endogenous basal insulin distribution profiles. For that, we have to develop a once-weekly basal insulin with a long and flat exposure profile, control tissue distribution properties and attenuated potency at the insulin receptor, and we will come back to that point. We would like to have a reduced variability by controlling fluctuations in the glucose levels during this week and maintaining an acceptable and manageable hypoglycemic profile. There's one clear limitation when we discuss an insulin given once weekly, and that's the fact that it's not easy to adapt insulin requirements fast because you have to wait a week before you have to make your next dosing decision. However, and this is important when you talk to patients, expectations are high from the side of the patients because they prefer definitely fewer injections, and the breakthrough in GLP-1 agonist therapy is the once-weekly GLP-1, and many of the patients think in this once-weekly rhythm already. And the idea is that this once-weekly insulin might improve acceptance, adherence, and even persistence on therapy. So when it comes to what kind of clinical parameter do we need, so pharmacology there is needed, so the PK and PD, pharmacokinetic and pharmacodynamic profiles of a basal insulin after a single dose. There are different parameters. There's the injection time, then there's a time to the maximum concentration, and then there's the terminal half-life for the PK. And then the duration of action is the time for in which we can expect a glucose lowering effect, which is usually measured in the phase 1 trials with the glucose infusion rate in a euglycemic clamp study. And the peak to trough ratio is also an important feature because it tells us how much insulin concentrations differ between the peak concentration and the lowest concentration before the next insulin dose is injected. So there are some limitations for our daily basal insulin analogs, and one problem remains, of course, when we use an insulin once weekly or once daily. That is the fact that we under-insulinize our liver, because when we inject insulin, it enters first the periphery and not the portal circulation, and is not seen by the liver first, like with our endogenous insulin secretion coming from the beta cells. At the same time, we tend to over-insulinize the periphery, which then leads to the tendency of weight gain and the increased risk of hypoglycemia. So, for clinically, the attributes for once-weekly insulin therapy, we would like to have an improved or at least similar glycemic control as we have with once-daily insulins with a low hypoglycemic risk, a reduced treatment burden with less insulin injections, maybe an approach to easier to overcome the therapeutic inertia on both sides, on patient side and caregiver side. On a molecular level, we would need a long half-life, at least for a week, a stable pharmacokinetic profile with low interpatient and intrapatient variability, and a slower clearance, which will contribute to the duration of action. And we have seen that before we moved from MPH insulin to insulin given once daily, like insulin degludec or insulin glargine U300. And they cover nicely the insulin need over a day, but when you stretch that for a full week, you need a much longer duration of action that we have to achieve. And we need, therefore, a very flat pharmacokinetic profile with a reduced variability, which then leads to the reduced injection burden. So what innovations are on the horizon, and I'm moving right into introducing to you the new basal insulins that are currently under development or will be available soon. So there are currently two compounds. One is insulin icodec, and the other is insulin Fc-Dora alpha. So let's start with insulin icodec. It has a side chain with a 20-carbon fatty D acid, and this leads to a very strong albumin binding, and albumin, the circulating albumin in plasma, but also the albumin in the interstitial fluid is the depot, has the depot function for that insulin. It also has some changes in the insulin molecule that reduces enzymatic degradation. There's a reduced insulin receptor-mediated clearance, which also prolongs the duration of action, and the time-action profile has a half-life of approximately 8 days, and this supports a once-weekly dosing in humans. Phase 3 is complete. It has been approved in Canada and Switzerland already for type 1 and type 2 diabetes. The European Medicine Agency recommended approval recently, and FDA, you might have heard the news, currently does not recommend it or recommend it against the use in type 1 diabetes, and we will come back to that in a minute during our presentations. The second one is insulin Fc-Dora alpha or insulin Fc-Dora. This is a very different molecule because it's a novel single-chain variant of an insulin that's fused on the Fc domain of a human immune globulin IgG. It's a homodimer. It has a reduced insulin receptor potency, but still full agonism. And the time-action profile is approximately 17 days and supports once-weekly dosing in humans. And this insulin is currently in phase 3 trials, and Eda will present the latest data on those both insulins. So when it comes to insulin icodec, you see here the molecular structure. As mentioned, it has a C20 icosane fatty D acid that binds to the albumin, half-life of 8 days, but it retains the same biological properties as natural human insulin when it binds to the receptor. So after injection into subcutaneous tissue, the diene monomers are then absorbed via the endothelium and bind to the circulating albumin. And how the dosing and the steady state, the mode of action works is indicated here. So with our first injection, first the insulin icodec is in the interstitial compartment of the subcutaneous tissue, then slowly enters the circulation, binds there to albumin as well as it binds to the albumin in the target tissues, in the intracellular space of the target tissue, and finally it binds to the insulin receptor, activates insulin receptor, leads to glucose uptake with some clearance. Then after a week, when you give the second injection, the number of molecules that are in the interstitial compartment that are circulating is increased. You have more effect in terms of glucose uptake. With the third injection, we are slowly achieving or coming close to a steady state, and we can say that after the fourth injection, when we have the same doses, we achieve steady state within 3 to 4 weeks. Or if we can change that and achieve a steady state much earlier by using a loading dose, which is the black line, by, for example, doubling the insulin dose and the first injection. When you switch someone from one insulin to this new insulin, you're achieving steady state conditions already from the beginning on. This was the mode of action for insulin icodec. When we look at the PK/PD profiles of week 5 on a once-weekly dosing, you can appreciate that there's a nice dose dependency and very flat profiles for many, many hours, which represents a week. And when we look at the glucose lowering effect, the pharmacodynamics effect of insulin icodec, you can see it's more or less equally distributed, and the slightly higher insulin levels we achieve on, or we get on day 2 and day 3 are actually the reason why in type 1 diabetes titration of that insulin might be a little bit more tricky than compared to type 2 diabetes. So the second molecule is insulin Fc-tora. As mentioned, it's a human IgG Fc domain that's fused with a single chain insulin molecule that has some changes in the molecule to again protect it against enzymatic degradation. The Fc domain then binds to the Fc receptor and helps to have a prolonged half-life. The half-life of this insulin is 17 days. And therefore, this formulation is compatible with a single-use or multiple-use devices and can be formulated with incretins together as insulin icodec can do. And despite this very different insulin molecule that you can see here, data have shown that it has a low immunogenicity risk. So there is no increased formation of antibodies in that molecule. So how is here the mode of action? How can we achieve this very long half-life? So when you inject this insulin into the subcutaneous tissue, it enters the blood vessel in the circulation. There, monocytes and endothelial cells internalize via endocytic vesicles this insulin, and this is then recycled into the circulation. That means that the monocytes and endothelial cells are the compartment for that insulin via the neonatal Fc receptor, which stabilizes the insulin action and gives us these very long pharmacokinetic profiles that we see with that new insulin. So dosing works here when we inject the first dose, it enters circulation and reaches the target tissues where it binds to the insulin receptor, has some receptor clearance. When we have the second injection, more insulin molecules are circulating, more are achieving or reaching the insulin receptor in our target tissue. And after 4 injections after a month, we are getting closer to a steady state level. After 8 weeks, we fully achieved that steady state. And when you use a loading dose, as you would expect for the other insulin, as for insulin icodec, we're achieving this steady state definitely earlier, after 2 to 3 weeks. This is reachable when we use a loading dose. Okay, and how do the pharmacokinetic profiles? So this is a single subcutaneous dose. We see a very nice dose response. Please note this is a log scale on the y-axis. And after 6 weeks, we have very flat PK profiles with insulin Fc-tora at different concentrations as indicated in this PK/PD study. Both insulins, both new basal insulins can be combined with GLP-1, can be co-formulated, so there will be a co-formulation available in the future. And why do we need, or why do we think about this co-formulation? Well, there's complementary actions for basal insulins. So the standard action of basal insulins are inhibiting hepatic glucose production, and the insulin effect on the periphery in adipose tissue and skeletal muscle. And when we add that with a GLP-1 receptor agonist, we have the decreased energy intake due to the appetite regulation with increased satiety. We have the glucose-dependent insulin secretion, the glucagon secretion, and the delayed gastric emptying, or the GLP-1 receptor agonism that we need. And when it comes to the ideal balance between efficacy and safety. So with basal insulin, we have a very good effect on HbA1c and fasting plasma glucose with very little effect on postprandial glucose. When we have a GLP-1 receptor monotherapy, we can achieve the same glucose-lowering effects for fasting plasma glucose, but also for postprandial glucose because of the insulin secretory effect of GLP-1. And when we have a combination of both molecules, we expect to have an even more pronounced glucose-lowering effect by having a substantial effect on HbA1c and fasting plasma glucose and postprandial glucose. Whereas when it comes to side effects, with insulin monotherapy, weight gain and hypoglycemia are clearly one of the side effects. When it comes to GLP receptor agonist monotherapy, there's the benefits in weight loss. There's a low risk of hypoglycemia, but still the gastrointestinal side effects. And if we combine this in one injection, we might have a weight neutral or a slight weight loss effect despite introducing insulin with the low risk of hypoglycemia and less gastrointestinal side effects. And icosema is the first fixed combination that is currently under development. So it's combining the once-weekly insulin icodec with the once-weekly semaglutide. There's 700 units of insulin and 2 milligrams of semaglutide in this preparation. And it will allow a maximum weekly dose of 350 dose steps, which is 50 units of a daily insulin given once weekly with insulin icodec. And that corresponds to 1 milligram of semaglutide. Okay.
Over to me. All right, so for you two, so how does the pharmacokinetic profile of once-weekly insulin influence its suitability for different patient populations, such as those with type 1 or type 2, and why do we need a loading dose? And I think maybe this is a good place for us to talk a little bit about what happened this week with the FDA in terms of type 1, as I'm sure many of you have that question.
Well, Edda, do you want?
Sure. So many of our patients, they're struggling with insulin injections, being compliant with insulin injections. So if you can achieve decent insulin glucose lowering action by injecting once a week, I think, and if your pharmacokinetics, supports that, I think it would be ideal for many patients for type 2. And I manage a lot of adolescents with type 1, and 70% of them are not in good range, and we keep admitting them in DKAs. And I know, I'm well aware of the FDA advisory panel decision, comments, but I think there is a huge role of a weekly insulin for type 1 patients too, provided that you select your patient well, and then you also have some safety, nets, like using CGM with alerts. I think there's a huge role for these insulin, in my view, as a clinician. And I think the loading dose, Thomas explained the pharmacokinetics and pharmacodynamics of icodec and efsitora so well. These insulins, so pharmacokinetics, how your body treats the medication, and pharmacodynamics is how glucose levels respond to insulin. And in this case, you saw that you need that loading dose to achieve a good level in blood. Once you're there, you're at the therapeutic, range, so you're good. Then your insulin is going to work well. I think that's one of the reasons we need that loading dose for these weekly insulins, just to get there, and to prevent some hyperglycemia, early hyperglycemia, when we're switching our patients from, once daily to weekly insulins. So that's my take.
Yeah, thank you. And I would like to add here that when you start a patient on insulin, a type 2 diabetic patient, a loading dose probably is not needed. You start with a low dose and you titrate slowly, weekly or twice weekly, depending on the response to the insulin. I think the loading dose gets important when you switch someone from other basal insulins, because if you would wait weeks before you're in steady state, that would give too much risk of hyperglycemia in that time.
Yeah, and the only thing I want to add is I noticed in Thomas's slide, which I'm sure many of you saw, that icodec profile on day 2 and day 3 and a little bit of day 4, there was a significant difference there in contrast to day 1 and day 4 and day 5. And Thomas mentioned briefly there that we would be potentially concerned in an insulin-deficient patient, like especially folks with type 1 diabetes, who are more likely to have increased glycemic variability, that on day 2 and day 3, they're going to potentially have a different expectation around their basal insulin. And do they need to do something different with their bolus insulin on day 2 and 3, given the profile, which is difficult to do? What happens if I'm going out for a run on day 2? Now, do I have to make my run on day 5 rather, because I'm more likely to have hypoglycemia? So I think I'm not in the FDA panel, but just reacting to this myself, I think you can see that the FDA is not looking at this from a type 1 or a type 2 perspective, because we all know how easy it is to misdiagnose and confuse the two diagnoses. And so they're looking at it as this is insulin molecule. Are we making this insulin available? And we know that even though these may be type 2 patients, they may be actually misdiagnosed as T1 or vice versa. So it's a tricky situation. And that's, I think, why the committee this week, the advisory board, has raised concerns. We may have some more discussion a little bit later about that, but something to kind of address up front.
Yeah, on the other hand, I mean, you will see the data when EDA presents their clinical trials. It works very, very well in type 2 diabetes. So the concerns around type 1 are worth mentioning, but I think the main population for a once-weekly insulin would be a type 2 diabetic population. Yeah, with that,
All right.
I'm adding over to you. Eda, please show us the innovations.
All right. Just a quick reminder about signing up, if you need to. If not, I'm going to start. Well, we have new glucose-lowering agents, so many of them very effective. But despite that, 20 to 25% of our patients with type 2 diabetes still require insulin treatment. So insulin is still lifeline for many of our patients with type 2. And the harsh truth is that many of our patients with type 2 diabetes are not achieving glycemic targets. An analysis from 2010 showed that it was only 57% of patients with type 2 were achieving A1C target less than 7. Thomas showed in other statistics it's significantly lower, and then there was a recent one which showed only 45 to 50% of our patients are achieving glycemic targets. So those percentages are not going in the right direction. So it's imperative that we have innovative tools, new generation insulins to improve management of diabetes, to improve glycemic control, and for an ultimate goal of reducing complications of diabetes. So how can we improve diabetes with new insulin treatments? I think it's fair to define what is an ideal insulin before we go there, before we start talking about new insulins. An ideal insulin, basal insulin, should improve glycemia to reach glycemic targets. We don't want pronounced peak action. Now this graph here shows insulin release from a healthy beta cell. For our meals, we want those nice peaks to keep the blood sugar in range. But when it comes to basal insulin, Mother Nature created the best system. And you can see, you don't need a lot of peak insulin action, especially unpredictable peak insulin action for basal insulins. Again, less unpredictability is ideal. We don't want any guessing games when it comes to insulin action. Is your glucose lowering action for that insulin going to be different across your patients? How about day-to-day variability? What happens if you inject it at different sites? So again, no guessing game is needed for an ideal insulin, whether it's basal or bolus, actually. We want low risk of hypoglycemia, especially for our patients with type 2 diabetes. We don't want significant weight gain. And people with diabetes face many challenges every day. You all know it's not an easy disease, and treatment adherence and persistence is quite challenging for all of our patients. It could be described, those injections could be described as a burden. Even for us, clinicians, there was a study that showed 2/3 of physicians actually described injections as a burden to diabetes treatment. So what can we do to improve treatment adherence and persistence, which will translate into improving glycemic control? Well, maybe fewer injections. Nobody likes too many injections. So how do we achieve fewer injections? By ultra-long-acting insulins, especially for basal insulins. That's why there was a significant, momentum in this field, and we're trying to address treatment adherence and persistence. We know that 70 to 87% of our patients with diabetes are missing basal insulin dose injections. They're not compliant with their treatment. 3 to 4 missed doses of basal insulin significantly impact glucose control. How about missed time insulin? If they're not injecting it on time, if they're injecting it late, that's a major issue too. And 5 to 6 missed time basal doses also impact glycemic control in an unfavorable way. So again, this brings us to ultra long-acting insulins, and once weekly insulins could provide unique opportunity to simplify basal insulin therapy to allow good glycemic control and ease burden of our patients, and maybe also reduce mistakes, medication errors too. I have so many people, their parents are on insulin injection. Every morning before they go to work, they go to their parents' house and do those insulin injections daily because their parents can't do it. So, if you look at the patient center, if you look at this from a patient-centered angle, those ultra-long-acting insulins, once weekly insulins, could be a major game changer for those families, for people with diabetes and their caregivers too. So Thomas already reviewed pharmacokinetic, pharmacodynamic data of once weekly insulins, and I'm going to try to summarize the evidence for once weekly insulins. What are the outcomes, and are these once weekly insulins delivering what they promise? So we'll quickly review 8 clinical trials for icodec, once weekly insulin. Onwards trial program is one of them. We'll also talk a little bit about some phase 2. FCTORA, once weekly insulin. We have 4 clinical trials, QWIN trial program, and some phase 2 studies. And then icodec semaglutide combination, 4 clinical trials, mostly combined clinical trial program. Now let's start with Onwards trial program, and let's dive into some data. This slide summarizes, this table summarizes Onwards trials, just main features of it. We have Onwards 1 through 6. 6 was for type 1 diabetes, so I'm not going to focus on that at all. We're going to focus on Onwards trials 1 through 5. These trials were, designed to demonstrate the, efficacy and safety of icodec once weekly insulin compared to other basal insulins. Comparators were insulin glargine, degludec, and some of the subjects were insulin naive, and some of the subjects were already on insulin. So if you take a look Onwards 1 and 3 and 5, those were insulin naive subjects. And comparators were, for Onwards 1, it was glargine. 2, 3, and 4, it was insulin degludec. And for 5, it was insulin glargine, either U100, U300, or degludec. And for 4, some of them, those patients were also on aspart insulin injections too. So these are, this is the main kind of like a summary of these trials. I think one interesting thing here is like, how do you decide, how do you initiate once weekly insulin? Because clinicians, we all know how to change the insulin dose or determine the basal insulin dose for daily insulins. But how do you do it when it's once weekly? So here is how they did it during those trials. First of 1 unit of icodec has a comparable glucose lowering effect to 1 unit of comparator basal insulin. So at randomization, the once weekly dose of icodec corresponds to 7 times the once daily dose of basal insulin. And for insulin naive patients, they started with 70 units of icodec and then titrated every week. And if you are on basal insulin already, they give a 50% additional loading dose, which equates to, instead of 7 times the basal dose, now you're multiplying the daily basal dose with 10.5. And then they titrated weekly depending on, fasting blood glucose levels, plus or minus 20 units for icodec. And you can see the little table there. Their goal was, especially in onwards 2, target blood glucose was 80 to 130 milligram per deciliter, which is the ADA target. So drum rolls, what happened? What were the outcomes of the study? Well, onwards trials, icodec reached a non-inferiority. So they reached the primary outcome. You can see, for all of them, you see our check marks. The order is off. Onwards 1, 3, 5, 2, 4. Confirmed non-inferiority. And then the other important thing was, look at the hypoglycemia rate. So clinically significant hypoglycemia, severe hypoglycemia, these rates were not increased with icodec use. And for some studies, for some of the trials, icodec actually was superior. So let's take a look at the next slide. This one is from a review study, and you can see on the top panel each onwards trial. The order is, this time it's 1, 2, 3, 4, 5. So for onwards trials 1, 2, 3, and 5, change from baseline A1C was statistically significant for superiority for icodec. So icodec actually did better during those trials. In time in range, most of you are familiar with those bars. The green is time in range, the yellow is, time above range, the red area here is time below range. During trials onwards 1, 2, and 4, insulin icodec showed a trend in greater time in range, for those specific trials. So time in range was either, same when you look at icodec outcomes and compare it to the basal insulin, or, sometimes slightly better. So this slide shows a meta-analysis, and during this meta-analysis, they actually pulled phase 2 data for icodec and phase 3 data, and weekly insulin icodec compared with daily insulin analogs showed a higher reduction in A1C. Another important thing was greater proportion of subjects reached target A1C levels below 7% when they were on icodec. And there was, again, no increase in hypoglycemia. There was prolonged time in range with icodec treatment, and there was no statistically significant differences in frequency of clinically significant and severe hypoglycemic events. Now I want to draw your attention to this forest tape graph, though. So this is your, each line represents a study, and this is your no effect line. And look at the diamond. This little diamond represents their, final study analysis for the meta-analysis, and it shows the weight outcome, and it favors long-acting insulin, meaning they found in this meta-analysis, icodec resulted in some weight gain. But then we have another meta-analysis, and during this meta-analysis, they mostly focused on phase 3 trials. So we have our, same diamond here, no effect line, and now we have onwards trials 1 through 5. But this time our diamond is on this side favoring icodec, meaning during this meta-analysis, they actually found that icodec patients lost some weight. And rest of the outcomes were pretty much similar in terms of reduction in A1C, time and range improvements, and hypoglycemia. How about some other safety outcomes? Nothing impressive injection site reactions and intrapatient variability. There was no significant, variability. Another important thing was there was no significant variability when you inject icodec at different sites, thighs versus abdomen. Now, let's switch gears and talk about Efsitora, QWIN trial program. Efsitora weekly insulin, there were 5 trials, but fifth one is type 1, so we're not going to discuss that. 1 through 4 is going to be our focus. And during this study, it was, insulin-naive patients. Also, some patients were already on insulin. And their primary outcome measure was also reduction in A1C. Secondary outcome measures were mostly, similar: time in range, time above range, time below range, and hypoglycemia. So we don't have a lot of, info regarding their data. They just did, press release. But what we know is, how they tried different dosing titrations for Efsitora. I'm not going to get into details, but they used a similar loading dose at the beginning of the studies for Efsitora 2. And they've shown that loading dose strategy found to be safe and effective in reducing transient hyperglycemia for those subjects. And what were their outcomes? As I mentioned, we just have press release for 2 major trials, QWIN 2 and QWIN 4, and it was Efsitora versus daily insulin. And outcomes of these studies showed the reduction in A1C was similar for Efsitora and the basal insulin. So it proved non-inferiority for Efsitora. And hypoglycemia rates were also similar. There was no increase in hypoglycemia rates. We have some data from phase 2 studies for Efsitora, a bit more detailed, and that actually aligned with what we've seen in those press release outcomes. In terms of A1C reduction, also non-inferiority was proved. And in terms of fasting glucose values, both Efsitora groups and basal insulin, fasting blood glucose dropped. Fasting blood glucose was slightly higher for Efsitora, but again, hypoglycemia rates, there was nothing significant in terms of hypoglycemia. And this slide shows time in range. Time in range, hypoglycemia was similar for all groups through 32 weeks for the Efsitora phase 2 trial. How about if we quickly compare time in range for Efsitora and icodec? You can see icodec time in range in this table, insulin naive, insulin treated, and insulin naive during the titration study. And right below that, it's Efsitora time in range percent. Again, insulin naive and insulin treated. If you look at icodec loading dose time in range, 72.9, non-loading dose 66. So time in range for icodec was actually pretty good, comparable when you compare it to other basal insulins. But you can see with loading dose, icodec achieved a higher time in range than those not receiving a loading dose. And for Efsitora, on average, the time in range was ranging between 60% to 76% for those patients. And Efsitora was well tolerated for phase 2 for phase 2 trials at least. And during phase 2 trials, there was an imbalance in hypersensitivity reaction, 6 for Efsitora, none for degludec, but we'll see how phase 3 trials will pan out once they release that data. And there was no variability for Efsitora as well, so it was low between day and between patient variability with regards to glucose lowering activity. Our final one is ICOSEMA, icodec semaglutide combined trial program. It's 1 through 4, and also some were insulin naive, some were already on insulin. And we have a press release. We don't have the full data set for this study. And just to give you some highlights, A1C reduction was similar for Icodec semaglutide group versus the daily insulin group. And there was actually, in terms of hypoglycemia rate, Icodec semaglutide did a better job with fewer hypoglycemic episodes. I think another important outcome was weight loss. With Icodec semaglutide, there was 3.6 kilogram weight loss for the Icodec sema group, and the other group actually gained weight. They gained 3.2 kilograms. And common side effects were mostly what you expect from GLP analogs, mostly GI effects, but it wasn't to a level that, you know, it actually there were severe GI effects. So what did we learn from these studies? What does the evidence show? Well, Icodec demonstrated superior glycemic control compared with daily insulins in 4 of the 6 trials, and in 2 of them there was non-inferiority. In insulin, Icodec showed a favorable safety profile. There was no increase in hypoglycemia and other side effects. There were no significant adverse side effects. There was no change in variability. Another thing that was reported from some of the trials was there were questionnaires about treatment satisfaction. And those were pretty, significantly greater for the Icodec group. Insulin efsitora demonstrated non-inferior glycemic control compared with daily insulins and a favorable safety profile in phase 2 clinical trials. And the combined study, Icodec semaglutide demonstrated non-inferiority glycemic control compared with daily insulins and superior reduced risk of hypoglycemia, along with really favorable, I'm going to call it, weight benefit in the combined phase 3 trial. So again, what's the take-home message? Well, we have evidence that scientific evidence indicating once-weekly insulin work. They either achieve similar reduction A1C compared to basal insulins or even better reduction at times. We're achieving same time in range or sometimes slightly better time in range. And side effects, adverse events are not high. And, these insulins, once-weekly insulins, offer a safe and effective option with a convenient dosing regimen, potentially reducing the burden of insulin therapy for people with type 2 diabetes. And it can simplify treatment for our patients and for their families. So, thank you for your attention.
Thank you. Thank you, Eda, for this fantastic overview.
So we've got 20 minutes or so left, so just quickly, I'm not sure we have, do we want to take this question? We've got a few questions. I think we're going to just keep moving along, and then we'll get them at the end. I'm going to abbreviate my presentation a bit so we can have a chat at the end, because I know there's a lot of interesting questions and things we can discuss. So maybe we'll move on and just in the interest of time, from this panel discussion. All right, maybe this is a question we can't go past. So who are candidates for once-weekly insulins? I've got a couple of thoughts. So maybe I'll start and answer the question to start off. So some of the people that I think about that could do really well in my practice are folks who, as we all know, who are really struggling to be able to remember, take their insulin. Shift workers. I have a lot of people who just really struggle, and even Degludec and U300 glargine don't necessarily solve that problem. I know with an endocrinology audience here, I'm sure some of you have patients who take their levothyroxine once a week, and they need supervision. So I could see some of my patients who have got significant psychosomatic issues, people who are institutionalized that may have significant benefit. I know I have some of my patients who come to my clinic so that our nurse educators can actually inject their GLP-1 receptor agonists once a week. So I could see a real role for that in my practice. Those are a couple of things just on the top line that I can think of. Any other thoughts from you guys?
Well, I think patients who are afraid of injections or are concerned about the burden of injections are definitely another group that would be very interested in a once-weekly insulin.
Anything from your side?
I agree. I mean, you pretty much said it all, but a lot of patients, I saw that big box, with the word art, compliance. If anybody's having major compliance issues, needle phobias, and I mentioned it, some providers are, like some caregivers, they definitely, I know so many families that I have that they prefer once weekly insulins. And I think there are still so many things we need to find out about once weekly insulins, like what happens if you exercise, what happens at the hospital when they're admitted. Maybe it's a better option at the hospital, maybe not. But again, there's so many potential patients that might benefit from it.
Great. So I think we've maybe already addressed the first question here, how do we start? And I think the second question, how we ultimately adjust glycemic regimens when you switch to once-weekly regimens. I think maybe just 2 sentences from each of you. What would you do if somebody was on glipizide, maybe Eder to you, and Thomas, if they're on semaglutide or tirzepatide at a high dose, what would you do?
Reduce the dose. I think when you have someone on insulin already, we have discussed it, the loading dose is very helpful. When you have on high dose of GLP-1, because of the co-effects you get on efficacy, you can reduce the GLP-1 dose.
Similar answer.
Similar answer,
Okay.
yes.
Let's keep moving along. What happens if a patient misses a dose?
With the once-weekly insulin, you just continue when you remember that you have forgotten your dose, and because of the long half-life, you have much better overlap of your profiles, and it's less relevant.
Perfect, that's good news. Okay, let's get to the last bit here. I know it's getting late and most of you want to get to bed. And it makes my presentation actually easier because the audience is a group of endocrinologists, and so a lot of this is very well known to many of you. But this is an interesting patient voice, and so this is actually a real patient that was interviewed for this, and it's actually quite striking and something that I'm sure many of you have heard.
And how I learned something was wrong is my husband and I were moving cross country. And that long drive, I had an unusual need to keep stopping to use the restroom. And then my feet started becoming numb. Once we got settled into our new home, I had blood work done, and that's how I found out I had diabetes. Shortly after, I fell and ended up being hospitalized when I split my lip open and received stitches and a prescription. My son took me to the pharmacy to fill a prescription for insulin, but I didn't have any instructions or any idea what to do. So we YouTubed what to do. When we watched the video, we realized we didn't have the needle and that was sold separately. So we drove back to the pharmacy, which is a 30-minute drive to get to, just so that I could take my first dose of insulin. Really, everything I've learned about my insulin has been from Dr. Google. I'm in rural North Carolina, so my resources are limited. I've just used the internet to try to get more informed about my diabetes and insulin. There has to be a better way.
Great, I'm sure many of you have heard that. And so this slide really just summarizes what many of us know as that insulin is not a prescription that we necessarily just send to the pharmacy and say, off you go and figure it out. There's multiple steps. And in the context of this conversation, there's less steps for a patient on a once-weekly insulin. I think that's the fundamental take-home point. We know that we have to teach patients how to use glucagon. That's part of the process. We teach our fellows that all the time. Somebody doesn't leave the office unless they know how to actually manage hypoglycemia that comes from insulin. We're also aware of this concern around hypoglycemia, so we tend to go slow with insulin. We tend to start slowly. We don't want them to walk out and lose confidence in the first time they ever take an insulin injection and have a hypoglycemic event in the first day. We know that impacts our relationship with the patient and their confidence moving forward. When we think about this, and I'm obviously framing everything for you guys, think about this into the future when these insulins become available. How do we use these insulins and think about these insulins in the same way that we think about the insulins that we use today and how we educate and prepare patients for insulin use? We know this, insulin's not a threat. Many of our patients see this as this very big needle. And here we're giving this very small needle less frequently, and there's power to that, obviously. This is another statement that I'm sure many of you have heard. Drugs don't work in patients who don't take them. And it's very, very self-explanatory, but I love to put it up because this is a potential opportunity here for us to improve this. So we've already gone through this data, and this is just a reiteration of the slide. Our patients struggle. I don't like the word compliance. I'm sure many of you don't like it either. Even the word adherence is a kind of nasty word sometimes, depending on how you think about it. But we know that we have a responsibility as healthcare providers to help our patients adhere and persist to therapies that we give them that they're going to be taking for the rest of their life in many of our cases. And I think this is a great opportunity for us to move the needle forward here. So this is the word compliant that I just mentioned that we don't like. As Brian says, I don't really like that word either. We agree with him. It's not like you're refusing the doctor's advice. You're just making the wrong decisions. We're asking our patients to make decisions every day when we're asking them to take basal insulin. What do they do when they have the colonoscopy? What do they do when they're planning to go for a run? What do they do? We're constantly having to ask patients more and more and more when they're doing these therapeutics. So we know we have to have shared decision-making with our patients, and we know that potentially these insulins are going to help us with the shared decision-making process. I think about Acosema in terms of the weight loss that Eda presented here is a really powerful conversation that I can use with my patients in future. We're already asking them what time of day potentially they're going to inject their insulin. What's an appropriate time for them? Now we're asking them when can they do this once a week potentially. Can I give them greater choices? I think that's what's really exciting about this field is that as insulins move forward, as Thomas mentioned, from the days of MPH, we now have so many more choices for our patients, which is really exciting. And we have an opportunity to discuss what their preferences are going to be. What do you think? Is degludec best for you? What about MPH? Is MPH still an option for some of our patients? Is it still on the table? Shared decision-making, this gives us greater opportunity there. And so we know about the disease. Many of us know a whole bunch more than our patients will ever know. We know the tests, we know the treatments, but the patients know what their expectations are for their own body, their lived experience, their circumstance, and what their goals are. And how do we align our insulin therapeutics and whatever other therapeutics we have with the patient's expectation and how that aligns with what we know. And that's what this is all about, really. This is just an interesting survey that I want to just go through, and it may not be surprising to most of us, but actually I was really surprised by the numbers. So this was published recently in February of this year. David Kerr and a group did a survey that they sent out to endocrinologists and patients, and it was about 400 in each group, asking them what their preferences would be if they lived in a hypothetical world where these once-weekly insulins were available. And you can see that 91% of patients and 89% of, it wasn't just endocrinologists, there was diabetes clinicians, there were some primary care docs involved and other diabetes clinicians. And you can see that the vast majority in a hypothetical world would choose once-weekly insulin. Without even knowing about it. And so that's pretty striking, and maybe the numbers are higher than I would have thought. And they also asked them on a Likert scale, a typical 1 to 7 Likert scale, those that were already using insulin, would they feel more confident that using once-weekly basal insulin would help them to achieve their goals? And more of them agreed, which is interesting to me why they would have thought that, but more of them did. And that there wasn't necessarily a difference whether they were insulin experienced or not. So the numbers were pretty impressively high. So I think our patients are excited and looking forward to this opportunity to be able to use these therapeutics. So this patient said, I would worry about any once-weekly medication. This is the flip side. What happens if you have a bad reaction? Now you're stuck with it for a week. I think many of us had to address that when the GLP-1s, the once-weekly GLP-1s came out. I remember I was pretty nervous going from liraglutide to Byetta to Bydureon and what happened? It wasn't potentially as bad for many of us as what we thought it was going to be. But this is another guy, Ron, who says, how big is the shot? Wow, imagine I need 100 units a day. Now I'm going to be taking 700 units. How much insulin is that? Maybe you're going to look like you've got a golf ball under your skin. And maybe that's something we'll have an opportunity to discuss that we haven't. Like, is this really the case that they're going to get this much insulin in their skin? So these are the questions we're going to have to address with our patients. Also, what happens when you have hypoglycemia? Am I going to be hypoglycemic for the whole week? And And this is a study that Thomas did, so I'm going to let him speak over this because he's the expert on this and this is his work, and he'll address that question.
Yeah, the question we wanted to answer was what happens if you give accidentally a double or a triple dose of your insulin, and we compare that to the Glargine U100, give a double or triple dose, or Icodec double and triple dose. We were looking into how fast hypoglycemias occur and how low patients did go, and there was no difference. So if a patient has a hypoglycemia, even with this long-acting insulin, there's no longer duration of hypoglycemia and there's no repeated hypoglycemia. It's just one hypo, you defend that with carbohydrates, and there you go. So there's no increased risk of prolonged hypoglycemia if patients are accidentally giving themselves a second injection.
Great. Okay, we're getting right to the end here. And so this is an opportunity for us to get some questions from you guys. So this is George, 58-year-old guy, he's got type 2 diabetes. He's coming to see his primary care doc. He's on metformin and glipizide like all of our patients today, but eventually somebody added some oral semaglutide. And so that was about a year ago. And his A1C is still not at goal. So 3 maximal non-insulin therapeutics. And he's having some hypoglycemia. And he's really frustrated by the amount of medications he's taking. So on everything else for hypertension and statins and everything else. He's got a BMI of 32. He's pretty sedentary. And he feels like he's failed. He doesn't want to inject medications. He feels like it's inconvenient, it's embarrassing. How's he going to do it? It doesn't fit in with his lifestyle. And he's worried that if he takes insulin, he's going to have more hypoglycemia. So a pretty typical scenario that I'm sure we come across. So some questions for you guys. What would you do next? And this is opportunity for the audience to respond. I'm not going to ask my panel colleagues right now. And if you don't have...
I'm hearing something from this side.
Okay, stop glipizide, put him on basal insulin. Sounds like a good plan to me. Yeah. Okay. Some of the... Say again? Add Jardians. Okay. So 4 non-insulin therapeutics. Okay. Any other options? Shout it out. It's okay.
Yes.
Get a loan from the federal government to pay for everything. Yeah. Okay.
That's beyond our pay rate, but yeah, we'll work on it.
Okay, switch to an injectable GLP-1 instead of the oral. Yeah, potentially reducing treatment burden there. Not as many pills he has to take. Okay. Say that again. Yeah, move from Ribelsis to Mounjaro. Okay. Exactly, and I think that's as we mentioned earlier, we haven't given you the whole story around all of these patients here. We don't have enough time to go through all of the kind of comorbidities and the patient's experience and what their expectations are. But yes, that's ultimately where it's going to land, and how you discuss this with your patient in the room and how you frame it for them. But I think all of these are potential options. I'd most probably get rid of the glipizide. His patient's already having hypoglycemia. It's right at the bottom of our therapeutic armamentarium right now, and I'd add most probably basal insulin because he's already on three non-insulin therapeutics with an A1C of 8.5. Am I going to get much significant benefit by adding a fourth agent? That would be my practice, I think. But I like the idea of Jardiance for, I don't know whether this guy has any compelling indications for Jardiance, if he has microalbuminuria or he's got previous stroke or something like that. So there's a lot of good options. Anything you guys want to add? We've got...
Nope, I think, yeah.
All right.
Great comments and plans.
Okay. What approaches would be used to discuss adding basal insulin? I don't think we necessarily need to cover that. No. Yeah, we're good to go forward with that.
Kind of already did, yeah.
Does anybody want to... Kristen, do you want to say something?
So,
okay, all right, let's move on then. And I think we're almost done. Okay, so this is the last slide. So despite all our advances with once and all of the really good insulins we have today, we have challenges still. And we now have the potential of new insulins that are coming down the pike that are pretty exciting, as well as the combination to connect them with GLP-1 receptor agonist therapy, which we all like and use. These insulins appear to be safe, particularly and effective in people with type 2 diabetes, and they offer a great opportunity for us to advance the needle, as we've already said a few times before. Okay, I think that's us. So we're going to do a post-test now, which is, I think, the same questions that you guys saw in the beginning. So you're all pretty confident in this initially. So maybe respond on and see if you're more confident than you were initially. Okay, that's great. Nobody's not at all confident, so that's good. Let's keep going. Okay, so now that we've spoken about the novel once-weekly basal insulins, are you more confident in using those in clinical practice? I'm hoping to see green.
Yes, thank you.
Yeah, fantastic. All right. I think I put myself in the somewhat confident still, quite honestly. Okay, so the same 49-year-old gentleman with type 2 diabetes, PCP sent in to you, his A1C is 8.2, he's on the metformin and glipizide like all of our cases, his BMI is high. What would you suggest? Great, yeah. It's actually gone up. Everybody said that in the beginning. Okay, so this is the scoreboard. Kristen, over to you.
Speed and accuracy, guys.
Okay, so 62-year-old female patient, type 2, 5 years duration on metformin, alone with an A1C of 9.2. This patient has a BMI of 24 though, without any signs of any complications other than having some glycosuria, and fasting glucose is in the 180 range. What would you do in this situation? Yeah, okay, I agree. Okay, JL still looks like close, and LCH, I don't know how to say that, it's close there. Okay, which of the following statements best describes the PK of once-weekly basal insulins? All right, good. That changed a lot from pre-test. So that's great. Whoa. What happened to JL? Okay, so in the systematic review by Robinson, you saw the slide, I think 4 or 5 times. Approximately how many missed basal insulin doses were found to significantly impact glucose control? Yeah, correct. Okay, so which of the following best describes the primary efficacy outcomes of icodec and on A1C reduction in onwards 1, 3, 5 in insulin naive patients? This is in the type 2 trials. Okay. Great. Wow, this leaderboard's pretty active.
Yes.
Ideology is leading now. I think, is this our last one?
Last question.
Last question, all right. This
Drum
is-
roll.
Okay, so which of the following statements regarding the safety profile of insulin efsitora compared to insulin degludec is supported by phase 2 study findings?
I want you to get this. No, not much of a difference.
Okay. That one was a little bit more challenging. All right, so ideology is the winner.
No, third place.
Oh, third place. Oh.
All right. If you're in the audience and not online, come see us and we'll give you a gift card.
Sorry, ideology. I pulled the trigger too soon.
Okay, then thank you. The program is over. Thank you for your participation. Please claim your credit and have a nice evening, either in bed or in the city.
Thanks, everyone.
Everything will be alright. She told me that the beat is mine. It will rock through the night. And where I go, can't explain, I'll never know. But it's beautiful. You can't take this away from me. Oh, the way I hear the melody, the waves bring clarity running through me. You can't take this away from me. Oh, the way I hear the melody, the waves bring clarity running through me. Hey, you can't take this away from me. The way I hear the melody, the waves bring clarity running through me. Come on, y'all. You can't take this away from me. Oh, the way I hear the melody, the waves bring clarity running through me. Yeah, it's running through me. Yo, I wear notes like coats, blues like dudes, warmth in the rhythm, soul that glues, that bounce to my bones, jazz in my spine. The hop is my home, rap is my grind. I'm grinding on the backside of life, we dance. She threw me a chance, her hands in my pants. Actually, my pockets holding me tight, whispering a dream I could hold in the night. Blood tight, a rhythm that's throbbing my vein. Wake up to write it on the pad, the pains. Like church, the organ will invite the tears. Like birth, the crying, let you know I'm here. Held by the song that gave me a name. Dressed by the verse that gave me a claim. It's just bass in the